question or something like that if you have any questions in the middle, because that's totally fine too. And so I just want to go back and look and see where we've been with COVID and kind of where we're going. COVID, I think, is the new flu, and monkeypox is the new COVID. So we'll just kind of go and look at that. Now, let me see. There we go. So the first, this is kind of how I'm going to go through it. Just tell you a little bit about myself. That's the whole, no disclosures thing. And then we'll go through statistics and long-term care. I'm really, my area of clinical expertise is really in depression and dementia. So I want to talk about that pre-COVID and how that's changed with COVID. Then we'll go through the pandemic, the consequences, and then kind of treatments and how we can kind of learn and improve from this, both from a mental health standpoint, but also from an infection prevention standpoint. And so those are kind of the topics that I'll go through. So unfortunately for me, I have no conflicts of interest. I always like people who can put stuff on there, because usually a disclosure, just so you guys know, for a conflict of interest means they're getting paid by somebody. So if anybody knows someone that I can have a conflict of interest with, please let me know, because I would love to be on that little list where I can put that on my board for Pfizer and I get a stipend from these guys, because that would be kind of cool. But I'm not there yet. But I've been working in long-term care, both assisted living, long-term care, post-acute care, inpatient settings and outpatient settings for about 20 years now. And like I said, my expertise, my area of interest is really in management of dementia with behavioral disturbances and severe depression, psychosis, that kind of thing. So when we look at the statistics of long-term care, it's really interesting, right? And this is what people don't really notice. In the nation, we've got about 15,000 skilled nursing facilities and around 30,000 assisted living facilities. So we have more residents in long-term care than there are people in Manhattan. So if something was affecting Manhattan, which Godzilla usually does, at least once every 5 to 10 years in the movies, there's a huge response and everybody is supporting Manhattan, and the government and everybody gets involved. We have more people in long-term care than there are in Manhattan, but we don't receive in our long-term care facilities, I don't believe, the same support from other people, other entities, as Manhattan would if they were under attack. And I think we saw that when New York went through COVID versus long-term care going through COVID. The other thing that I think most people don't realize, but you guys all know, is we're serving the most frail people in the country in long-term care. And we're doing so with the least amount of registered nurses and the most amount of care aides. Okay. As you guys know, 20 years ago, long-term care may have been a place where someone went to just live the rest of their lives. Now it's a post-acute care place that's really seeing the equivalent of hospitalized patients 10 years ago. Okay. But these hospitalized patients we're caring with less staff, right? And less educated staff and almost no social workers. Okay. And so I think that makes it really difficult. It makes it really challenging. And it makes what we do even more impressive when you look at who we're caring for. And if we look at this right now in residential, communities, assisted livings, over half the people are 85 and over. And that's 40% in our skilled nursing facilities. And if you look on the right there, half people, 40% of people have dementia, right? 30 to 40% have depression. And then the big indicators of who's at really highest risk, besides those for becoming acutely ill and having a bad outcome, it's diabetes and heart disease. And we have a lot of that. So we are taking care of people who are the oldest, the most frail, and have the most medical comorbidities in our facilities. And we really need to keep that in perspective when we're looking at our response to COVID and how we can go forward with COVID, and what we're saying to people when we're trying to explain to them, why do we have to be much more protective of our population than, let's say, Kroger is when people are going shopping. So dementia, depression, delirium are all issues that every one of us faces. Just really quick, dementia is a chronic condition with memory loss, but memory loss is only the beginning, right? Memory loss is only what you see as the outward manifestation to begin with. As all of you know, you have increased risk of falls because your balance is poor, right? People start losing weight because they lose their appetite. What a lot of people don't know are their skin changes with people with dementia, which make your skin more frail. There's also changes in your immune system. So think about the brain as the motherboard, the computer system for your body that runs everything, right? And so if it's not functioning well, what happens? Everything doesn't function well. So the immune system for someone who's older, over the age of 75, is already about half of what it was when you were younger. But also the immune system, if you have dementia on top of that, also works at about half. So our patients are much more susceptible to any infections. Depression We all know it. We've all seen it. Much more subtle in older adults. But there's a lot of studies out there that talk about depression and say, hey, if you have depression, your chronic and acute medical issues do worse. And there's tons of research and data out there. So people with depression have a much higher rate of death from myocardial infarction, from heart failure, more hospitalizations from pneumonia. They just do worse. And this is the population that we're serving. We're serving this extremely frail population. And we know that over time, they already have cognitive decline. So what we're looking at for normal aging are the green bars. And when usually we get somebody, they're probably over there in the red already, right? When they're coming in to live with us, they're in the red. They're mild or moderate dementia, usually probably at moderate to moderate severe for some of our places. And the person moves in and then the family member asks us, what? Wow, they've really declined in the past 6 months. Well, it's not because they moved into our facility that they declined. It's because they're on the rapid descent of decline when you bring them in to see us. And that's just what happens. And that's something that I talk to people about all the time. The reason why they're seeing us is because they're in the steep decline that maybe you weren't noticing because you were seeing them every day and so involved in caring for them. And now that other people are caring for them, you can take a step back and see what's happening. But so we have people who are already in a state of steep decline. So they're frail, they have more disease, they're older, and they're declining much faster than other people, okay? And this is just a cool slide looking at dementia and depression. Like I was saying before, how depression can really affect people, and most don't understand that. If we look at the bottom left of this slide, that's a normal control. So a PET scan is basically we give you a bunch of glucose and see how much is uptaken by the brain. Red is hot and good in this instance, yellow is functioning, and the blue and the green are more cold, right? So if you see the normal control NC in the bottom left, you've got a lot of uptake coming on. And then if you look at the other diseases, FTD is frontotemporal dementia, AD is Alzheimer's disease, DLB is Lewy body dementia. They have a lot less uptake, okay? And so we see that and we see, okay, brain activity is declining in people with depression and dementia, but that's just dementia. Here's depression. Look at the right side and look at the left side. So the right side is not depressed. The left side is either a lawyer or someone who's depressed. I saw Maddie was on here. Both of her parents are lawyers. So you can show this, Maddie, to your parents and explain to them the difference between normal and lawyer. But anyway, so depression has that same decreased brain activity, very similar to dementia. And like I said, worsening physical health. So look at this, increased risk of stroke, death and heart failure, higher blood pressure, higher mortality. And look at this, bottom one, what? Decreased immune response. So our patients are all at highest risk for infection, okay, for weight loss and for bad consequences physically because of their emotional well-being. And you guys all know this, that there's a big cycle of depression, right? So someone is having negative thoughts, they go through a stressor, maybe the family causes a problem or they're having stress at work or they're medically ill, most common for us. That becomes physical problems, so they don't sleep as well, they're not eating as well, they have low energy. So then what happens? Well, they don't feel well, so they stay in their room. They become withdrawn, decreased activities, and then that makes the negative thoughts and feelings even worse, and you get in this big cycle. And I think that's why from a behavior standpoint, you'll see most of our facilities now, as opposed to 20 years ago, are really into, hey, let's get people out of their rooms, get them doing activities, initiate for them, get them involved socially and physically, because we're really trying to break these cycles. But one cycle that's come up through COVID is loneliness. And we really don't think about loneliness. We think about pure depression, but not loneliness, right? And what is loneliness? Just a discrepancy between what I want for social connection and interaction and what I actually receive, okay? And most people don't talk about being lonely, but it's a big deal. And we know that loneliness is a huge problem for our older adults. And it's almost ironic, because if you look at somebody living in an acute or an assisted living facility, they're surrounded by people, but they can still feel lonely. They can feel not part of the group. And that lack of community can really make them feel lonely. And that loneliness has the exact same negative impact on their health as depression. Okay, so if I were to show you a slide of loneliness, exact same as depression is with how it negatively impacts you. Okay, and so this is something that we really need to look at, and we haven't really been looking at, but we can see now, and it's really kind of come out through the pandemic. So let's go back to 2020, January 20th, right? We all know first cases, first cluster, right? We don't call it an outbreak anymore, we call it a cluster. Was at Life Care Center of Kirkland, 101 resident cases, 55 staff cases, and amongst the two, 46 deaths. And nobody wanted to be the next facility. And the news, the press, really hit that facility hard, didn't they? It was all negative. Okay, even though the facility, just like ours, is taking care of the most frail, the oldest, the most likely, to get diseases because of all their chronic conditions, no one cared, right? And so then what started happening? News outbreaks and pictures, everything. 2 dead, 100 hospitalized at an outbreak in Gallatin Rehabilitation Center. In Virginia, a long-term care has become the largest known coronavirus outbreak. Cookville long-term care facility, all over the news, right? All over the news, how we had these death homes going of COVID, right? And what were we doing and what weren't we doing? Meanwhile, you saw pictures of people in hospitals in Manhattan, right, which was having a higher mortality rate than we were, but they were being hailed as heroes, okay? And everybody was working really hard in the hero-ship of Manhattan. But in our long-term care facilities, it was, what are you guys doing wrong? Why are you guys failing, okay? So we look at the long-term care COVID statistics. So United States cases are up to date. That's on the right-hand side there. There's been 92 million cases in the United States and 1 million deaths. In long-term care, we've had 1.1 million cases, okay? Compare that to 91 million, I think that's doing pretty good. 154,000 deaths, so rate of 13.5% nationwide. What's really sad on this slide, I think, is that we've had 2,500 staff members in long-term care facilities pass away because of COVID. These aren't frail people, right? These are people who are doing their jobs and working. So 2,500 people who have passed away, saving and protecting our older population, okay? As of right now, 84% of our residents have been vaccinated and boosted, but only 54% of our staff have been vaccinated and boosted. If we just looked at the first vaccination series, I think we did a really good job. We were about 85% nationwide for staff having that vaccination, but we're only at 54% for getting the boosters. So I really think that's something we need to work on is, one, we've got to get the 16% of people in our facilities who have not had vaccination and boosting completed. And then we really need to talk to our staff about getting boosters, okay? And we can talk about that later on if you have any questions about how to convince people to do that. So overall, in the United States, 13.5% mortality rate, which is pretty good compared to before. Used to be much higher than that. But after the vaccination came in, people are getting sick. But as you guys know, they're not getting as sick, requiring hospitalization and passing away at the same time. So in Tennessee, we had our first case January 20th. That was in Gallatin, or I'm sorry, that was in Williamson County, someone who came from Boston, on March 5th. First case in Davidson County, March 8th. And then within a month, we had our first cluster in Tennessee, okay? And here's a picture of that cluster. The response was dramatic. I did not know that there was a mass casualty transport bus with Nashville Fire until this day. And everybody in that facility was evacuated, if you recall. Patients went to one of 4 different hospitals and were treated there. And I don't think the facility reopened to accept residents for about a month, if I recall correctly. And so what's the dilemma? Like we said before, a vulnerable population that requires significant caregiver support. The caregivers worked at many facilities at that time. It was difficult to isolate and maintain people. Limited supplies. If you guys remember, people were going out to Home Depot to get supplies because they weren't getting the supplies needed. Asymptomatic spread, which we didn't know about in the very beginning, made one case rapidly become 100. And there was no coordination. So what we set up, and most of you were on that, was the long-term care cooperative, where we were working on trying to prevent, contain, treat, and then return our facilities. And we partnered, as all of you guys did, with state and local authorities, and actually with the CDC, and did some real-time monitoring. And this is kind of what we found. This is very early. And if you just look really quickly, that red line, the first like reddish purple line, is the first facility that had the outbreak. And within 2 or 3 days, 65% of their residents were positive for COVID, okay? The blue line was one of our NHC facilities that we worked very closely with, where we were able to contain, and this was one of the first containment success stories in the United States, COVID from spreading. And that's when we went to full isolation in the entire residential facility because we were learning that cohorting wasn't working, okay? Later on in the blue line, you'll see a little peak, and that's just simply because there was a caregiver in full PPE who was feeding patients who needed to be fed and somehow gave them COVID despite having full PPE. And that's where we learned, hey, having PPE is not enough, it's education. And you can see we were doing really well, and we kept the spread in almost all the facilities around 20 to 30% when there was an outbreak, except for that green dotted line. That was difficult because of Bob. I've changed the name, but Bob had dementia and was a wanderer and wouldn't wear a mask and wouldn't stay in his room. And so when you have a dementia care facility, an assisted living dementia facility, really difficult, right? As you guys all know, to contain the spread. But we learned a lot of lessons doing this. And in Tennessee, okay, I want to point this out, how good we've done, 10.8% mortality rate. That's really good. And in Tennessee, 27,000 cases. So we were able to keep the cases down compared to the general population. We had a less percentage of cases in Tennessee than nationally, and we had a lower rate of people who died. And that's a congratulations to all of you on this telephone call or web call or whatever you call this thing, because that is your hard work reducing the mortality rate by 3%. And you say, oh, 3% is not much. 3% is a lot to the people who survived, right? And there's a lot more of people who survived also because of how few people in Tennessee caught COVID in the residential facilities, again, because of your strong work. So then this question came up to me. If the death rate among vaccinated people is less than 1%, why should we still have strict COVID measures? Why should we mandate vaccinations? I mean, we've got everybody vaccinated. If your mortality rate's so low, why don't we just open everything up? And the reason why is it's still high. So some studies coming out after people had a double dose of the vaccine, the initial series, I think it was in Missouri and Kansas, and one in New York, showed that the vaccinated resident mortality rate was still 20 to 35% because they're very frail. So that's the answer. The answer to that question is we are trying to protect our vulnerable, frail adults, and getting sick with COVID, it doesn't feel good, and it does have that higher mortality rate, and we're doing everything we can to prevent that. Here's current statistics of the graph of cases in Tennessee. This is just in Tennessee, not in long-term care. You can see back on November 20th, that was the initial outbreak in 2020. November 30th one, that's our Omicron variant, November 30th, 2021. And you can see right now, August 7th, we've had a little bit of a blip coming up, not as big as the other ones, probably because of the vaccination that we've had with all of our residents and all of our community members, but you can still see we're still there. And if you look, you can see that an outbreak or a cluster or whatever you want to call this seems to occur about every 6 months, right? So when this one goes down, we're probably looking at the spring of having another one, which would make sense because that's right when flu season kicks in and, you know, you're done with Christmas. So we'll probably be having another one at that point in time. So what are the consequences? So Florence Nightingale once said this: to any but an old nurse or an old patient, the degree would be quite inconceivable to which the nerves of the sick suffer from seeing the same walls, the same ceiling, the same surroundings during a long confinement to 1 or 2 rooms, right? That's a long time ago that she said this, but it's true. Being in the same room and seeing the same thing and not being able to move about can really harm somebody from an emotional standpoint. And if you see what we did, and we had to do this, okay? Decreased visitation. So on the left is before. You can see that half of our residents had visitors 3 or more times a week. After, 5%. No visitors, 10%. After, 72% of our residents had no visitors weekly. That's a huge change when you think about it, especially when most of our residents are functioning on a 2 or 3 year old level if they have dementia. So imagine taking your 2-year-old and not having them see their family members again for a long time. Decreased outdoor activity, similar, right? If you look at people who had outdoor activity 3 or more times a week, it was at 50% before. Twice was 15%. And you can see those numbers just drop. And now we had 60% of people having no outdoor activities once coronavirus went in. Again, this had to be done to stop the spread, because what a lot of people don't realize or don't remember is we didn't have vaccines when coronavirus came out, okay? And we were having a lot of people get ill and pass away. And so what were residents saying? If the virus doesn't kill me, the loneliness will. I have depression, why keep living? I've become more anxious and depressed due to the separation from my loved ones. I don't have any appetite and I'm losing weight. Okay. I've been depressed, requiring medication approximately 6 weeks after restrictions were put into place. So residents were saying, hey, I'm really feeling depressed. This is affecting me. And remember, depression and isolation lead to worse physical outcomes as well. Some more things. This is from what were family members saying. She's dying a slow death. Her brain's turned to mush. And published in one of our papers was a nice, wonderful article. Is isolation killing our older adults in long-term care? And they showed this picture and said, hey, this was Helen before, and this was Helen after the lockdowns. Now, I noticed some different things in this picture, like we've got some new skin tears and we've got a neck brace on, so maybe we fell. And, you know, so I mean, I think there's a lot more to it, but this was all blamed in the media on lockdowns. Remember, if you worked in a hospital at this time, you were a hero. If you worked in a long-term care facility, you were creating the problem. And staff morale started declining, didn't it? Nursing home neglect, deaths surge in the shadows. Maggots, rape, and yet 5 stars. Okay? We're killing our elders now. So tons of negative press, despite the fact that we are taking care and doing our best and providing more love and care to our older adults. But yet, for some reason, we're the evil ones, okay? And these are the images that are being shown everywhere on the news at the time, okay? Ambulances outside, people in gowns taking, you know, people away, and it just wasn't good. So what are the themes, right? It's concern for self and family, concern for residents, right? This is how our staff are feeling. There's a lot of regulations, right? They're not getting the PPE they need. Okay, they're feeling burned out. They're getting publicly blamed for everything. And they're not getting recognized for what they're doing. I mean, this is what our staff was going through at the time. So it's not just depression and isolation amongst our residents. There's depression and isolation amongst our staff who are doing all of this work during COVID. And so the staff concerns were pretty simple, right? I want to make sure I have the right protective equipment. I don't want to take the infection home. I need access to testing, which they didn't have in the beginning, okay? I need access to childcare. Okay, I want to make sure that I'm prepared to take care of this virus that I don't know much about, right? And I'm not getting much information because it's changing all the time. And it changed every day from the government, and they were changing how things were going. Families were also impacted. So families go from being able to visit their loved one regularly to not able to get any communication, not knowing what's going on, feeling that staff is stressed, and this caused almost like a cycle of a negative perception of quality of care coming on in our facilities because they couldn't see. They were being isolated themselves, and so families were getting upset. And when they talked to families and said, how do you feel? Worried about the residents' care. The loved ones were getting worse since they were last seen. They weren't able to grieve or say goodbye. But there was a few who said, and I actually had one family member say this to me, it was a relief. I felt I had a duty to come every day to see mom, and this made me not be able to do it, and I was able to get my life back. So for some people who were having, I guess, family caregiver fatigue, it was almost a relief for them, okay? Family comments that we've heard. She'll die of boredom, she'll die of the isolation, okay? She loves seeing her family. That's so important to her. During the couple of weeks we didn't visit her, we kept getting bad news. Every time we called, they said, mom hasn't eaten, mom hasn't done anything. I started to think she's going to die. I don't know how to cope with this or how my mother copes with this. This is what we fear the most. We can't be close to her in her last days. I have a constant fear that my mother will die, and I always keep my cell phone close by. So family was extremely nervous and stressed, right? And so what do we have? We have residents who are stressed, anxious, and depressed. We have staff members who are stressed, anxious, and depressed, and we have family members who are stressed, anxious, and depressed. So how do we get through this? Well, we really, as you guys remember, we went to just prevent, contain, treat, and return. Okay, so right now I just want to focus on current day. How do we prevent and contain now? Because I know there's a lot of questions about that. And then how do we treat and return now? And then I'll end up talking about what can we do for that depression, isolation, loneliness, and what can we do for our residents, for our staff, and for our family members to try to rebuild the community and make a stronger community than we had before. First thing for prevention and containing is vaccination. Vaccination, vaccination, vaccination. That's number 1, 2, and 3. We really need to convince people to become vaccinated. One of the big things I hear all the time right now is, If vaccination doesn't stop you from getting COVID. You doctors are all getting COVID even though you've been vaccinated. That's true. I just had COVID July 1st, and I've had 3 vaccinations, right? But I didn't die from it, and the COVID wasn't as bad as it could have been. So I think the main thing is we need to get the perception of the vaccination prevents you from getting COVID or doesn't. It doesn't work for COVID, right? You'll still get COVID, so why get vaccinated? Vaccination does prevent COVID, but even more so, what vaccination does do is it stops COVID from becoming a severe illness that makes you be hospitalized, okay, and becoming a severe illness that kills you. And that's the most important thing. And for the 15% of our residents that have not been vaccinated, we need to talk to their families and discuss this with them. Or if they haven't been boosted, find ways to get the booster, because I know it's more difficult, especially since we don't have this massive kind of, Walgreens, effort to vaccinate everybody. And for our staff members, really saying, hey, 85% of you have been vaccinated, 50% have not fully vaccinated, but you've gotten your 2 shots. Let's try to close that gap and find that 35% of people and get them to get their booster. Find ways to encourage them to get their booster, because I think it's really important. Hygiene, proper hand washing, okay, proper use of gels and cleansers, and then I'd say right now probably almost a re-education on proper putting on and taking off PPE, because remember, you can get sloppy with it easily and do it just a little bit wrong, and with the newer variants of COVID, you're going to end up with COVID then. And so I think we did this very well in the beginning and middle stages of COVID, but we really haven't gone through there. So I think going back and saying, hey, this is how long you have to wash your hands, this is how you do it, the 20-second thing, every time you enter or leave a room, please use the cleansers. And then also maybe, hey, let's see you put on some PPE and let's see if we remember how to do it, successfully. Because though that, along with vaccination, is really your steps of preventing, okay, that are really important. And then also people coming in to the long-term care facilities, right? I know they think it's burdensome, but we really need to make sure that the people coming into the long-term care facilities have been vaccinated, are wearing masks, are using proper hand hygiene, because that's really how we're going to try to stop the spread from getting into our facilities. Testing. Fortunately, now testing is really, really available, and the rapid tests are wonderful. And so the testing is an important component. And here's some recent CDC guidelines for that, because I know there's been a lot of questions on this. So newly admitted residents, okay, and residents who have left the facility for over 24 hours, okay, regardless of vaccination status, should have 2 tests. One immediately when they get there, and if that one's negative, 5 to 7 days after their admission. And the reason for the 5 to 7 days here is they're looking for someone who's asymptomatic. Now, if one of those newly admitted people develops symptoms, right, well then obviously you're going to test sooner, okay? And if one of those asymptomatic newly admitted residents develops symptoms, you're going to want to quarantine them. But what the CDC is saying really is every single person coming in or has been gone for more than 24 hours needs to have a test immediately, and then 5 to 7 days later. Next line, asymptomatic residents with a close contact with someone, regardless of vaccination status, should also have the 2 tests, okay? So you want to do testing sometime after the exposure, maybe a day or so, okay? And then again, 5 to 7 days. So you're looking at a double test for a newly admitted resident or an asymptomatic person with a close contact, okay? And neither of those matter about your vaccination status. Now, residents who are up to date with all of their vaccine doses. Now remember, up to date now means boosters, or have recovered from COVID in the prior 90 days, who've had a close contact, should wear source control, that means a mask, okay, and then be tested like I said before. But they don't need to be quarantined. So if you have a close contact, okay, of somebody who has COVID, but you're up to date on your vaccinations, or you've had COVID in the past 90 days, you need to wear a mask, during your, 1 and day 7 testing or day 5 testing, but you don't need to be quarantined. Okay. It's different if you're not vaccinated. Okay. Because if you're not vaccinated, then you're much more of a risk. Okay. For people. And so that is one of the benefits of being vaccinated. Now, you may want to quarantine that person if they're severely immunocompromised. So if that person has cancer and is undergoing, immunotherapy for cancer, then that may be the case. But that's kind of more of a case by case kind of status. Now, residents who are not up to date with the vaccine doses, okay, and who've had a close contact should be placed in quarantine after exposure, even if viral testing is negative. Why? Because they're at high risk, especially with the newer variants, to actually have COVID, test negative, and then test positive in 5 days and be asymptomatic spreaders, okay? Healthcare providers caring for them should use full PPE. Residents can be removed from these precautions after 10 days if they don't develop symptoms, okay? Or after day 7 if that test is negative and they don't have symptoms. So this is one of the reasons why I think we can use this for our family members to say, hey, this is why vaccination is good, okay? Because if they're vaccinated and they're around somebody, let's say you come visit them and then you have COVID next day, if they're vaccinated, life goes on normally for them. If they're not vaccinated, they will be confined to a quarantine for 10 days. And so, and that will create more isolation for them and won't be very good for their mental health. So I think that that's one way that we can try to convince people to get vaccinated or to have their loved ones be vaccinated. And then finally we have, and I use the word isolation instead of quarantine just to kind of put it out there, we are isolating people, right? And we're causing them to feel isolated. And when we look at the CDC, okay, they say, hey, first, try to find a care unit or care rooms for COVID-19, okay? Ideally, where that is physically separated from the other rooms, okay? Could be a floor, a wing, or just a room at the end of the hall. And ideally, you can identify healthcare workers who only work in the COVID unit when it's being used, okay? And not working with other residents. So we're trying not to, during the same shift, go back and forth, if possible. If not possible, because of staffing issues, which we know are really great right now, then you really want to work on your hand hygiene renewals and your putting on, taking off PPE, and just kind of re-updating that. We'll look at treatment. There's really 3 treatments out there. The first one, and I'm not going to try to pronounce these things, but it's a monoclonal antibody, so we just call it the monoclonal antibody. This one is given intravenously. It's a one-time injection at an infusion center. There's a risk of an anaphylactic or allergic response to it. And so typically for this one, someone's in a facility, they developed COVID, they're at risk, you'd send them to like Vanderbilt's infusion center. They would be there for about 4 hours, would get the 1 hour infusion, be monitored for an hour before, hour after probably, and then, be transported back home. And it has to be done within 5 days. So this was actually the first treatment, and this is the monoclonal antibody. Second, remdesivir is another intravenous therapy, but this is not a monoclonal antibody. This is an antiviral medicine, okay? Given within 7 days. So this is the only one that's given within 7 days, whereas the one previously and the one coming next are 5 days. So really right now, when we're looking at who gets this, it's people who are within the 5 to 7 day window, who missed the 5 day window ones. And you're like, oh, it's day 6, we can still give this and try to help them from becoming really ill and needing hospitalization. However, this is intravenous and is a 3-day therapy. So it's 3 days in a row. So you have to go to the infusion center 3 days in a row to receive this one. And it does help though, okay? And then the newest one, Paxlovid, which is what would be preferred and is the preferred option, okay? This is actually 2 antivirals, okay, which are given at the same time. So you can see on the package there's a gold and a blue. The gold is the morning dose. It's a blister pack. That's how it comes, where you take all 3 pills at one time. And then the blue is the evening dose, where you take all 3 pills at one time, and you do that for 5 days. Now, you need to start this within 5 days of developing COVID, Okay. There's a lower dose if someone has renal function problems, if their GFR is low. There are 1,001 drug interactions. And so on the bottom of this slide, I've kind of put down, you can just type in Paxlovid drug interactions. There's a www.covid19 treatment guidelines at the NIH, which you can look at, and it can show you. There are so many that there's no way you're going to remember them, but they're significant. So for example, if you're on amiodarone, you can't take Paxlovid, okay, because it interacts. If you're on blood thinners, you'll need to reduce the doses while you're taking Paxlovid. So there's a lot of drugs that have to be stopped, a lot of drugs that are not compatible, that if you are on, you cannot take Paxlovid at all, and then other ones where you have to adjust the dose. There are a lot of them. And so with our population and the fact that most of, at least my patients, are on 10 or 15 medications, it's really important to look through the drug interactions on this website or another one and make sure it's okay for the person to receive. Okay. People who get Paxlovid or take it feel much better usually within a day of starting. Okay. But there are 3 really big side effects. One is taste. I took it when I had COVID, and you get this horrible metallic grapefruit taste that stays, it's secreted by your salivary glands into your mouth, and it does not go away for 5 straight days. You can tell when you're due to take a medication because it starts to get better, but it is there, it's disgusting, and it's probably one of the worst tastes you've ever had. And it almost makes you go, do I really want to take this? So that's number 1. Number 2, everybody taking it will get diarrhea, liquid diarrhea. So I just tell patients to expect these 2 things. Expect the horrible taste in your mouth and liquid diarrhea while you're taking the medication. And then, as President Biden has now learned, there's a small chance, about 3% of rebound, where you can take it, do a lot better, and then have rebound disease where you're infectious again afterwards. Okay. And that's why President Biden took Paxlovid, was doing better. They kept testing him, and he tested positive again, and he was feeling bad again, and that can happen. It doesn't happen much. I think they said it's about 3 to 5%, but it can with Paxlovid. And so for me, when I had COVID, I caught mine in Britain. I waited till day 4 to take Paxlovid because I figured, okay, I'm just going to start getting it on my, I'm going to get better on my own. Well, I didn't get better on my own. I had the BA.5 variant. I started taking Paxlovid about 2 days later. I started feeling a lot better from it, and I didn't get the rebound, fortunately. The other thing that a lot of people get with Paxlovid, now that I just said that, is fevers. So when you start taking it, you will get sweats. You'll start getting like the night sweats and the chills. And I think that's because of the medication in your body kind of fighting very intensely the virus. And so that does happen. So bad taste, diarrhea, and kind of hot flashes, chills, and some fevers. But it's a very effective treatment. And it's recommended for every single person who's over 65 and has a medical illness, or every person over 85, just because of their frailty. So when we look at the treatment, remember we're talking about if you have COVID now, 10 days of quarantine. Now, when you look at the CDC guidelines, it's interesting. They say if you're in a home setting, you can quarantine for 5 days if you test negative on day 5, but you still have to wear a mask until day 10, right? Because if you test negative on day 5, they're thinking, hey, you don't have any virus in your nose, you shouldn't be infectious anymore. So you should be able to wear a mask until day 10, which if you're not infectious anymore, why do I have to wear a mask? So it's kind of confusing. But again, it says on the CDC website, if you're in a home setting. Now, what I find really difficult is most of the residents we have in a home setting are not able to wear a mask because they're kind of more the higher functioning people with dementia, and they're not going to wear a mask, right? So I think really the standard is 10 days of quarantine. If you have somebody that you can test after day 5, right, and they will wear a mask and remember to wear a mask every time they're out of their room, then you could probably allow that. But I think that's more for independent living and non-memory care assisted living. I don't think that's going to work well in long-term care, which is not a home setting, or in memory care assisted living, where you're really not going to have people who are willing to or capable of wearing a mask the whole time. So how do we improve from that depression isolation? So assessment plans. So just finding ways to assess people for isolation, which we don't do. And maybe creating visiting plans for residents in the care plan. So just some thoughts for the future, and that's that we could start assessing for feelings of isolation and start planning for it. Now, when we look at isolation, there's been a lot of work done on it. This slide is just showing all of the different scales that have been developed to determine if someone feels isolated. Bottom right, you'll see UCLA loneliness scale, and right above them, you'll see the De Jong loneliness scale. Those are really good because they're easy to administer. And so I've got an example of the De Jong loneliness scale here. I experience a sense of emptiness. If you say yes or more or less, you get a point. Higher points are worse. Okay. There are plenty of people I can rely on when I have problems. Okay. There are many people I trust completely. I miss having people around me. There are enough people I feel close to. I often feel rejected. And the higher points, the more likely you are to be lonely. And simple questions that we can ask people. And so how can we try to help residents not feel lonely? Well, remember when we're wearing masks all the time? Yeah, well, we still are. Maybe name tags with photos so they can see what you look like, okay? Use their name when you speak with them. Say good morning and good night. I mean, these are things that we try to do. But when we get busy, sometimes we don't. Ask them how they're feeling. What do they need? Okay? When we're giving them medications, talk to them. Hey, you know, this is your medication for blood pressure. Listen to them. And one thing we lost during COVID was the touch. So many people, almost all of us were social people, healing with touch. Just touching somebody on the shoulder can mean so much to them. And so I love this picture here of healing with touch. So getting back and realizing we're not just here working, we're here caregiving. We're here, and part of that care that we really need to focus on is those interpersonal reactions that we have with people. And you guys know it, you see it when someone's face just lights up when you're talking with them. Now, you guys, many of you know I've got llamas. That's why I have this picture. So some other kind of cool things, visitation with therapy animals, I would recommend llamas. They do spit though, so you got to be a little careful there. And the one on the right, the llama in the white there, does not look happy right now. But anyway, simulated presence therapy, okay, which is basically where, you know, people can have a recording that they can listen to. Photo albums, reminiscence therapy. A lot of times outside of people's rooms or in their rooms, you guys have, you know, photos of their family and things that were really important to them. Robotic pets can work. And we all know that lots of our residents really enjoy a stuffed animal or a doll, but just finding things for that person that can make them feel part of the community. Outdoor activities, gardening, laugh therapy, okay, music therapy, which we all do, letter writing and cards. So letter writing and cards both ways. Have them, if they can, write a letter or write a card to give to their granddaughter. Or, you know, local school children can write cards and letters or do artwork. And so here's an example, okay, of a local school that during COVID did artwork and sent it to one of the facilities for people, okay? And, you know, you look at that and, you know, everybody got a piece of art and it really makes them feel like they're part of a greater community. It makes them feel really good. Telehealth visits. This was one of our ICUs. And so, you know, a way to communicate with people, okay? Making sure there's adequate Wi-Fi in the facility. Lots of online activities. I was on an airplane flying here and it was like, I was just, you know, messing with the screen. And you can, I don't know if you guys knew this, but on some of the airplanes, you can chat with somebody in a different seat. So you can go like, oh, I want to talk to a person in like seat 35A and hit the button. So if there could be resident-to-resident chats online where they could talk to one of their friends, okay? And broadcasting activities to rooms if this is possible. Dance steps in unison, bingo, where when people are isolated in their room, they still have activities coming to them through a kind of like, you know, new internet technology. So just things to think about, okay? And then different activities. And so this is how to handle loneliness in different categories. So for example, if you look at early life, okay, people have memories, right? Their own furniture. You can get a bus tour of their old neighborhood or the reminiscing items. And then relatives, phone calls and family dinners and having grandchildren visit. Then you have their own recreations, like what were their personal hobbies? Did they like to garden? Did they like to paint? Or do they like group activities, which may be therapy, pet, music, prayer? And then new networks, right? And that's what we were talking about before, bonding with staff, finding new people that are your friends, you know, having pub nights I really like, networking and meal times. So you're looking at one, kind of the reminiscence, the earlier life, two, finding the hobbies and the recreations they would like to do, and three, developing new networks, different ways to have residents feel more part of the community. And then as much in-person touch as possible, even if it's through glass. But really, there's nothing more important for many people than seeing, feeling, and that feeling is tactile and it's touch, to feel like somebody is there, right? Now, what about staff? Staff have gone through a really, really hard time. They've been vilified in the news media, right? They're getting sick. Their colleagues are passing away. Every staff member knows of someone who has passed away who was healthy, right? So they're nervous. And a lot of staff members do not feel empowered to ask questions. So we need to listen well, okay? And that can be just asking, okay? It could be creating leadership visits or actively seeking input, okay? Maybe a suggestion box, but finding ways so that the concerns of our staff members are met, and they're met in a way where there's no anxiety, and that they know that they're heard. Leading them, right? I take for granted what I know. And so I think it's important to regularly re-educate, regularly update what's going on. Just because I know it doesn't mean everybody else knows it, right? And do it over and over and over again. Make sure that there's just-in-time training so that people feel comfortable with what they're being asked to do, especially if they're being asked to do something outside of their usual scope, right? Which happens a lot, okay? And kind of go through, hey, this is what's going to happen if you test positive, or this is what's going to happen if, Bob over there tests positive, and how we'll take care of it. And making sure that we're visible, I think, is really important. And just being there and being accessible to help relieve a lot of the stress. And then showing support, right? Recognizing and celebrating the success, showing appreciation, okay? Discussing, so there's no fear. Hey, if you get COVID, don't worry, we'll find a way to help you, right? If you need to come and work, we can find a way to help you with childcare. Hey, we have testing. We can give you a test if you need to test your child if you get it. Just realizing all the anxieties that people may have, right? Who may not have the same access to the medical knowledge that we have, or the medical testing kits we have. If my son has COVID, I can easily get a test kit, right? It's not the same for everybody. So just understanding that and showing that care and support. For families, being very transparent in communication. A lot of times just regular newsletters, regular meetings, okay? Showing appreciation for the families and what they're doing with caring, and making it clear for the families that we all have the same goal. And our goal is for their loved one to be as healthy as possible and to live as healthy as possible. And this can be very difficult for family members who say, well, I see them declining because they're not seeing me, right? But just, hey, well, what can we do then? Can we do a non-traditional visitation, right? I got in trouble at our facility with the state because I had a family member who had COVID take care of their loved one who was dying who had COVID. And they said, well, the family members aren't allowed in the facility. I said, they've got COVID, the loved one's got COVID, they're dying, they're on hospice. Well, I would let them take care of them. That's what they want to do. And I was able to convince them, but just thinking about how things are. Why are the policies so strict? Well, I think we've talked about that today, because this is the most frail population and we don't want them to pass away earlier than they are meant to because of COVID, right? My loved one is declining, what can I do, right? Because that's the big fear for family members, that they're going to decline, they're going to die, and I'm not going to be there. And so just discussing that you've been there your whole life, let us be there for them now. And we can find ways through video chats and other things to have you be there. But really being transparent in the communication, especially if they can't come to the facility, because the minute they can't come to a facility, they feel like you're hiding something. And then I think the biggest thing is remember that heroes are working here. This is my last slide. Remember who you are. You guys have basically made it through the COVID pandemic's worst parts, I'm hoping. Caring for the most frail, vulnerable population we have, okay? And you've made it through it, and you've done it, and you're stronger, and we've learned kind of some flaws that we've had in our systems, and we can improve those. But just remember that everybody, and I think when you go back to your facilities, think this is a hero's work here day, or have a hero's work here day, because our long-term care facilities didn't get flyovers from the Blue Angels. Our hospitals did, but our long-term care facilities didn't. So I think it's really up to us to say, hey, guys, You are really appreciated. You've done a great job. Let's all celebrate our success, okay, and not focus on the negatives, because I think this could have been a lot worse, and it's not. It's really good, and it's really good because of all the hard work that everybody on this call and thousands not on this call have put into it. And so that's the end of my talk. And so I can take questions now if you guys have any.
Yeah, thanks, Dr. Legner. We have a question here that was in the chat that came up about Paxlovid a little bit ago, and it's Nancy Drennan asks, if you take Paxlovid, should you retest if symptomatic after recovery, even though you could test positive for 90 days?
Yeah, that's a tricky one. So if you've if you're testing positive 10 days later, then no. So what happened to President Biden, I think, is a good case. So he was taking Paxlovid. They tried to do the, hey, in 5 days, if you're negative, right, then you're clear and you can just wear a mask and go out. And so he tested negative on day 5. Because he's the president, they kept testing him, right, and found out that, hey, he went positive again. So then he put him back. But that's exactly correct. You can test positive for a very long time. I think if you take Paxlovid and you're feeling good, you're fine after the 10 days. If you take Paxlovid and you get symptomatic after recovery, you can test positive, and that could just be because you've never tested negative, right? Or it could be because you're tested positive again because you have rebound. That's a hard question, right? And so I would say that for most people, you take it if you feel better, okay, completely better, and then a couple of days later you feel worse, I would retest. And if you're positive, you consider yourself to have rebound and to need isolation again.
Great. If anyone else has any other questions, please feel free to send them in the chat or just ask them right now. Well, if no one has any additional questions, I've also sent 2 new things in the chat. Again, there's a link to register for CNE credits. If you're a nurse and you would like CNE credit for attending today's chat, please fill out that link. There's also a link for a session evaluation, something we do on our end to just make sure that the webinars are going well and get some feedback from you all. So Dr. Legner, thanks so much for joining us today. And people, if anyone has any additional questions kind of coming out of this, feel free to send them to me. I'm the person who sent the invite for this meeting. So if you have any additional questions, send them my way, and I can always make sure Dr. Legner has a chance to respond to them. So thanks so much for joining us today. And yeah, I'll send the recording out tomorrow as well. So take care, everyone.